Hello everyone, myself Dr. Rajesh, Assistant Professor, Department of Cardiac Anesthesia. Today I'll be speaking about intraoperative assessment of the tricuspid valve. In this, we'll discuss about anatomy, pre-bypass echocardiography and post-bypass echocardiography. And coming to the introduction, tricuspid valve plays an important role in several clinical disease states, including left-sided valvular heart diseases and heart failure. And the development of functional tricuspid regurgitation is directly associated with increased morbidity and mortality. The most common etiologies that cause functional TR results from either RV dilatation and dysfunction from left heart diseases, including cardiomyopathy and mitral valve diseases. Imaging the tricuspid valve using transesophageal echocardiography, that is TEE, seems more difficult than imaging other cardiac valves due to not only the complex valvular structure but also the anterior and far field distance from the probe. And the focus of the TEE during the surgery would not vary from that of preoperative TEE. We should consider anesthesia-induced changes of ventricular contractility, filling status and vascular resistance when interpreting these images. Before going into the echocardiography part, we should know about the anatomy so that we will know what we are looking at. The tricuspid valve is the largest and most apically positioned among all the 4 cardiac valves, and normal orifice area is between 7 to 9 square centimeters, and it's typically composed of 3 leaflets which are of unequal sizes. Typically these leaflets are referred to as septal, anterior and posterior leaflets respectively. The anterior leaflet is the biggest and the longest one with most area and with most range of movement. The posterior leaflet may have multiple scallops and is the shortest circumferentially. It may not be clearly separated from the anterior leaflet in approximately 10% of the patients. The septal leaflet is the shortest in radial direction and is the least mobile. It is attached to the tricuspid annulus directly above the interventricular septum. It is inserted into the septum approximately 10 mm apically to the septal insertion of the anterior mitral leaflet. This implies apically displaced. Coaptation of tricuspid valve normally is at the level of annulus or just below it with a coaptation length of 5 to 10 mm. This excess coaptation length functions as coaptation reserve, allowing some dilatation of the annulus before the malcoaptation occurs. The papillary muscles and chordae form the tensor apparatus of the tricuspid valve. There are 2 distinct papillary muscles, anterior and posterior, and a third variable papillary muscles. The largest muscle is typically the anterior papillary muscle with chordae supporting anterior and posterior leaflet. The posterior papillary muscle, which is often bifid or trifid, lends caudal support to the posterior and septal leaflets. The septal papillary muscle is variable. It may be small or multiple or even absent in up to 20% of patients. Chordae may arise directly from the septum to the anterior and septal leaflet. The septal and anterior leaflets of the tricuspid valve connect to the interventricular septum, and the anterior and posterior leaflets depend on large anterior papillary muscle along the RV valve. Because of the fixed length of the chordae, displacement of either the RV septal or lateral valve positions will affect tricuspid valve coaptation. The normal tricuspid annulus is D-shaped and non-planar with 2 distinct segments. A larger C-shaped segment that corresponds to the free wall of the RA and RV, and a shorter relatively straight segment that corresponds to the septal leaflet and the ventricular septum. The tricuspid annulus is a dynamic structure with significant changes in its area during cardiac cycle and is larger at end systole or early diastole and during atrial systole and also under different loading conditions. Normal tricuspid annular circumferences and areas in healthy subjects are 12 plus or 1 minus centimeters and 11 plus or minus 2 square centimeters respectively. Finally, 3 important structures lie in close proximity to the tricuspid valve. The non-coronary sinus of Valsalva is next to the commissure between the anterior and septal leaflets. The atrioventricular node and bundle of his cross the septal leaflet attachment 3 to 5 mm posterior to the anteroseptal commissure. The right coronary artery exits the right coronary sinus of Valsalva and courses in the right AV groove posteriorly to the crux of the heart, where it takes an acute bend and continues down in the interventricular sulcus. This is how in sometimes to find out the annulus of the tricuspid valve, right coronary artery can be taken as a landmark. Coming to the echocardiographic findings, the primary goal of pre-bypass TE in TV surgery is to determine the valvular etiology, if any, tricuspid regurgitation severity and hemodynamic consequences. For etiology and hemodynamic consequences, to evaluate the tricuspid valve leaflets or apparatus morphology, annulus size, right ventricle dimension and function, and pulmonary artery systolic pressure, and for TR severity, the color Doppler jet area, vena contracta, flow convergence, and hepatic vein flow reversals are seen. Based on the comprehensive preoperative TTE exam, transthoracic examination, the pre-bypass TE exam would quickly double check the TV morphology related to pathological mechanisms with better image quality than TTE. There are 4 standard TV views. One is mid-esophageal 4-chamber view, mid-esophageal RV inflow-outflow view, transgastric RV inflow view, and transgastric tricuspid valve short axis view. This is the first view, that is mid-esophageal 4-chamber view, where we can see the septal and anterior leaflets. This is mid-esophageal RV inflow-outflow view, where you can see septal and posterior leaflets. And this is modified bicaval view, which is here also we can see anterior and posterior leaflet. And if we turn a little bit to the left, that is counterclockwise, we can even see septal leaflet. And this is transgastric 2-chamber view, where we can see posterior and anterior leaflets. And this is transgastric right ventricular basal view, where we can see the all the 3 leaflets, posterior, septal and anterior leaflets. In transthoracic echocardiography, we measure the tricuspid annulus diameter from the apical 4-chamber view, a diastolic diameter more than 40 mm or more than 20 mm per square centimeter, showing significant annular dilatation. In 2D transesophageal echocardiography, we measure annular diameter from both mid-esophageal 4-chamber and mid-esophageal RV view or biplane view at the end diastole. At least 2 different cut planes with or without color Doppler imaging are required to evaluate tricuspid valve morphology and regurgitation. Hemodynamically significant chronic TR leads to enlargement of the RV, RA, IVC and ultimately deteriorates RV performance. The interventricular septum has become flattened in diastole due to volume overload or in both diastole and systole with pulmonary hypertension. The RV dilatation is indicated as a linear dimension of more than 42 mm at the base and more than 35 mm at the mid-level from RV focused view, or relatively size of RV is larger than that of LV. Multiple parameters have demonstrated the clinical utility of using TE, such as fractional area change, that is FAC, tricuspid annular place systolic exertion, that is TAPSE, and tissue motion annular displacement and RV strain. RV FAC is measured by endocardial border tracing from the standard mid-esophageal 4-chamber view focused on RV end diastole and end systole phases, and it can be derived using this formula, and the value showing less than 35% indicates RV global systolic dysfunction. For evaluation of longitudinal RV systolic function, TAPC is commonly measured, and it can be measured using M mode, cursor aligned along the RV free wall as parallel as possible to the movement of tricuspid annulus, and less than 17 mm is considered abnormal. However, TAPC using TE is a challenge to align with the lateral wall. Therefore, several modifications has been used to measure lateral tricuspid annular displacement using 2D or a speckle tracking algorithm. Global longitudinal peak strain of the RV free wall is also considered a reproducible and feasible index for RV function, with the advantage of angle independency and prognostic value. These are various various images showing the first one showing, that is image A, showing RV FAC where we can trace the endocardial border, and B showing TAPC, and C is TMAD, and D is longitudinal strain of the RV. Coming to the pulmonary artery pressures, among the hemodynamic assessments of the RV, pulmonary artery systolic pressure estimation using TR velocity is the most commonly performed and reported. PASP can be reliably determined from the peak TR jet velocity using the simplified Bernoulli's equation. That is, with 4 times the velocity of the tricuspid jet square, when added to the RA pressure, it indicates PASP. And if there is no RV outflow obstruction, PASP is correlated well with RV systolic pressures. Coming to the TR severity, according to the 2020 AHA guidelines, it is staged into 4, where is normal, B is progressive tricuspid regurgitation, C is asymptomatic severe, and D is symptomatic severe, where the valve hemodynamics and hemodynamic consequences and clinical symptoms are shown. In all these stages, central jet area occupying RA, vena contracta, and effective regurgitant orifice area and regurgitant volume are considered. Severe valvular lesions such as flail leaflets with no cooptation or severe annular dilatation with marked leaflet tethering in 2D might be enough to show severe TR. For further hemodynamic flow information, qualitative or semi-quantitative imaging of color flow regurgitant jets, vena contracta width, and proximal isovelocity surface area diameter, that is PISA, and upstream vein flow is recommended. Traditional TR severity quantification with the effective regurgitant orifice area or regurgitant volume may not be suitable for a busy intraoperative monitoring setting. Coming to color Doppler jets, the color Doppler is primarily applied for detection of valvular regurgitation, visualizing the origin and 3 jet components, that is area, vena contracta, and flow convergence. Optimization of the color gain and Nyquist limit is required, and one could expect a slightly larger jet area with TE due to higher transducer frequency. A large central jet occupying more than 50% of the RA or any eccentric wall impinging jet would be considered severe TR. Coming to vena contracta, the vena contracta is the narrowest portion of the regurgitant flow immediately downstream from the regurgitant orifice. Because of the cross-sectional area of the vena contracta being similar to the effective regurgitant orifice area, the vena contracta is an important parameter to determine TR severity. Vena contracta width more than or equal to 7 mm is considered severe TR. As the shape of vena contracta is usually ellipsoid, it is necessary to have additional orthogonal imaging planes. Coming to the flow convergence proximal to the regurgitant orifice provides a well-known semi-quantitative parameter of the PISA. Simply shifting the baseline of the color scale in the regurgitant's direction jet at Nyquist limit of 30 to 40 centimeters per second. The Pisa radius is measured from the point of color Doppler aliasing to the vena contracta. A radius more than 0.9 centimeters at the baseline Nyquist limit of 28 centimeters per second shows severe TR. Coming to the hepatic venous flow systolic reversal, the hepatic venous flow systolic reversal is an additional qualitative parameter suggesting severe TR. Coming to the cardiopulmonary bypass TE, post-surgical TE surveillance is a critical to provide opportunities for fixing leftover lesions or unexpected complications immediately to avoid unnecessary future open heart surgeries and is so called safety net. Given the hemodynamic status, they should perform the post-surgical TE during the transition of the cardiopulmonary bypass, primarily focusing on TV surgical results following by other basic surveillance including cardiac function and extracardiac fluid collections. We should examine the morphology of a prosthetic valve or ring and its function using TEE depending on the surgical procedures. Color Doppler imaging is necessary for detecting residual leaks. A tricuspid valvular mean pressure gradient of less than 5 mmHg seems acceptable, but this depends on the heart rate and volume status. After effective communication between on-site surgeons, echocardiologists and anesthesiologists, decided upon either a continuous successful weaning process or an unfortunate but necessary additional pump based on TE information. Thank you.